everybody. So I'm here to talk about embedding QI in education. So why QI? And I think Susanna's done my job beautifully. What are the benefits of QI? Unfortunately, we seem to be on the same page. So there is a wealth of research of best evidence-based care out there. And certainly QI can help translate research into local context. And you've been hearing it again and again throughout the day. There's a plethora of data and learning that's out there that tells us what we're doing wrong and how we can get patient care right. And certainly QI can make the right happen and start to put that learning into practice. But it's really tough, and again we've heard today how tough it is to make all of this happen in practice. Real life problems range from the simple to the complicated, to the wicked, to the wild problems, to the big hairy problems, where there's a lot of uncertainty, that there isn't necessarily a right or a wrong answer, but you're looking to see what's the best solution and how do I navigate my way through that. And certainly QI can provide a means to do that. And then we have the paradox, because our efforts to make people better are paradoxically having a negative effect on the health of the population. So NHS England is the largest public sector emitter of greenhouse gases. So that's more than Heathrow, or to put it another way, more than Estonia. But QI can provide those opportunities to really maximise the sustainable value of healthcare. How we can minimise the environmental costs, how we can minimise the financial costs, and whilst we're also adding social value at every opportunity. And the recently described SUS QI framework certainly provides a means to how you can build sustainability into every QI effort. And QI can provide a means to respond to that theme of learned helplessness, and certainly we felt that very strongly throughout the mid-STAS report. And also to how do we respond to poor motivation and malaise that's really felt a lot by junior doctors, that we can do something. And as Susanna also described, that you can also start to put the fun back in what we do. You start to change the conversations and how we work together. So that's all well and good. Lots of really reasons why we should be doing quality improvement. And QI's been around for a long time for doctors in the guise of clinical audit. It's been in the curriculum for years, but seemingly not very well done. And in 2009, Emma Stanton did an audit of audits, which really just told us that junior docs weren't really enjoying doing it, and we weren't really having an impact on patient care. And it was very much felt that this is all about data collection and all about the tick box. So how could we shift, moving from that really traditional approach of change, where often there's lots of effort, you do a big push, and then everyone gets a little bit bored with it, or the junior doc moves on to the next thing and everyone goes, oh, thank God for that, and everything just folds back down again. So how can we make it so that we get sustainable, small-scale changes that really make that difference? How is it that we could shift QI from being a silo activity or a solo activity to involving the whole team? And how could we shift QI from being what's really felt like an add-on? You know, you're a bit like a smartphone. You have an app for QI, one for leadership, one for management. So how could we move it from an elite sport or a tick box activity so that it was really the very fabric of what we're trying to do? So, took the challenge on back in 2010, and here at the RCP we piloted how to enable quality improvement to happen in practice with core medical trainees, trying to move away from the data collection to actually how do you use the data to improve, and using that model for improvement as the approach. So very much about PDSA cycles. And that's really when learning to make a difference was born. And what we learned was that supported quality improvement in action, trainees really liked it. What we also learned was for the first time, what we were really seeing is that trainees were starting to make a difference to patient outcomes. And really, and should not be underestimated, The supervisors, the consultants supervising those trainees, loved it too. There was a huge amount of learning to be had through this. So very much about setting expectation, that this is part of what we should be doing in our everyday practice. Something about demystifying terminology. The language used in QI can be really off-putting. And then not least how we use terms like audit. Audit for improvement, or is it audit for assurance? Bringing to life what we do, lots of examples. And it's great to have enthusiasm, but you do actually need a little bit of knowledge to understand how you're putting QI methodology into practice. So having some coaching around you, having some core staff around you to help support you, and that you are supported at every level, including consultants, and saying that this is part of what we do as a doctor. But fundamentally, having a curriculum that really supports this activity. There is no doubt that assessment still drives learning. And this learning from Learning to Make a Difference also told us that there was a disconnect, though, between training our junior doctors and our supervisors in quality improvement and actually what was happening at the front line. So how could we bridge that gap? I think quality improvement needed to be seen not just as another training requirement, but actually a way of working in a clinical setting. It was about how could we translate that theory into practice. And I think as doctors, we're very aware of Miller's Triangle in terms of how do you achieve clinical competence. So the bit about that you know how to do something, so you're fact gathering, that you know how to do it, so you can interpret that data, you can show how you do it, you're demonstrating, and then you go out and do, so that's your performance. And it really, is that job done? So I would say that we need to take clinical competence to the next step, and that's very much thinking about critical reasoning and decision making, going beyond just that patient interaction. But it's about, there is a difference between what we actually do in practice and what we should do. There is a gap. And by recognising there's a gap, then is it that we justify that gap, mitigate that gap, or improve it? And once we can see that actually, yeah, there's room for improvement, then we can start to see the relevance of how quality improvement embedded in education makes a difference in the real world. And the one thing that we constantly learn along the way is actually quality improvement is not easy, it's tough. It's about change, and that involves people. So is it about 1,000 flowers blooming in what we do? Or is it that we're setting people up to fail and that we're just letting them wilt? And boy, can that be really demoralising if you're part of that. So we need support. We need real supporting infrastructure around us. It's what I call the virtual hug. Yeah, my logo hasn't quite worked yet. That's another one of them. I've still got a bit of work to do on this. So, with that in mind, in 2012, we then took all the learning from Learning to Make a Difference and took it down to organisational level. What could we do to make this work in practice for every specialty, for every trainee in every specialty, with their teams across an organisation? And what we learned was that for QI to be effective and meaningful, that this needs to be core hospital business. It needs to be aligned with trust strategies. There does need to be a core team. However altruistic you are in wanting to improve stuff, there are so many competing demands that it must be multi-professional and even more powerful where you've got meaningful patient involvement. That there is something important about a communication strategy around this, because messages get lost along the way, but it's also a showcase about how can you celebrate what people have done but also share learning. So in all of that, and with an agenda where I would say across the board, where QI is like the buzzword, this is what we should all be doing, but is it really catching on? And we know from a report that we published this year, we're working with HQIP about how do you use national clinical audit to drive improvement. We learned that despite people thinking yes, they really can see the value of it, but it's just not seemingly working in practice. And the biggest reasons why was around time, was around having headspace, and it was again that supporting infrastructure, that virtual hug of support. So then, 2015, building on the work that we'd done and the work of others, 35 different organisations then came together under the auspices of the Academy of the Royal Colleges with patients to see what could we do to enable quality improvement to happen in postgraduate training. And certainly, what we needed to do to begin with was to understand what were we talking about, what were the definitions. This is a 4-nation piece of work. That's the definition for England for quality, but each of the other 3 nations have a different definition, but there's a lot of commonality. But we agreed a consensus about what do we mean about quality improvement. So very much that understanding of the complexity of the healthcare environment in which we work, about applying a systematic approach. It is going out and testing what works, what doesn't, but measuring as we go, and remembering that it's all about the patient and the difference that we can make. And underpinning that is, what does quality improvement education mean? Well, it does mean having some knowledge and understanding about improvement science, but very much then about those transferable skills, leadership, how do you manage complexity, how do you reflect and learn, and what about sustainability and understanding about how human factors relate to this. So, in 2016, we have our lovely shiny new report with 8 recommendations. And essentially those 8 recommendations stated that yes, we do need a common curriculum, a portfolio of quality improvement activities that we should learn and go and test out and do in real life. But to do that, we need to have training in quality improvement. And what was interesting, one of the trainees, as part of that, described it that it should be like doing CPR. It should be like basic life support, that everybody is exposed to it, involved in it, but you'll have different layers of understanding, and you'll range from basic to expert. Patient involvement needs to be meaningful, but can be wide-ranging in how that is. And it should be business as usual for clinical and non-clinical staff in job descriptions and part of our appraisal. That a repository of shared practice would be so helpful. So if you're doing improvement in one area in the country, what about if you're doing it in Kent, what can I learn from others? That yes, that's supporting infrastructure, and that supporting infrastructure is where it's aligned, that what's the national directives to you get to college and specialist society level, to when you get to the regions and deaneries, and then when you get down to organisational level. It needs to be aligned, otherwise it's very confusing. Board leadership and role modelling, how critical is that? If they're not part of the drive for this, anything that you try to do can get lost. And going forward, that there needs to be continued momentum to keep getting this right. So that's lovely, nice report. I love this from George Pickering, which is that so many excellent analysis of the present defects in medical education, and no country has done less to implement them. And that was back in 1956. So we did take the next steps, the so what, and that was then 4 working groups that were set up looking at particularly around revalidation and appraisal. So for me, it's that connection between undergraduate, postgraduate training, but also continuous professional development. Most of us spend our lives not in training, but outside of it. So if revalidation and appraisal and what you're talking about as quality improvement activities don't align with postgraduate training, there's an immediate disconnect. We've certainly influenced the GMC supporting information that's just come out this year. I would say that we've still got a little way to go. A repository, so that's now being developed, and all of this goes live at the beginning of next year, and lots of signposting to how you can get access both resources, but also how do you access the good stuff that people are doing. The leadership and connectedness, so that continues to be how do we align and work together so that you have bodies like Health Education England or NHS Improvement and its equivalent in the 4 nations working together, aligning the direction of travel. And then the biggie, so we are launching the curriculum. This is a cross-college consensus. Never has there been such great cross-college consensus and agreement that this is the core quality improvement activity going forward. So this is really exciting, and it will be, as I say, going live in 2019. But again, I come back to the so what, because that's all very nice. It's sitting there on a website. We're trying very much to get traction going forward. So I would say, yes, we are trying to do, again, that so what. So this is with the launch of the new curriculum with the generic professional capabilities. Every curriculum is being rewritten to include them. The internal medicine curriculum has already been agreed by the GMC and goes live in August. And this is about how do you signpost the quality improvement activity for trainees and trainers to be part of through that. And the ARCP Decision Aid, the annual review of competence progression tool, is a really useful way to signpost as to what are the expectations that a trainee through a programme should experience as they go. But we're also specifically going out to test the quality improvement curriculum through what's called flexible portfolio training. So this has been in response to enhancing junior doctor morale, particularly felt so strongly time of the junior doctor strike. What could we do to help make their working lives better? And flexibility came out again and again and again. And as a college, we've responded with HE in terms of identifying that for registrars, if they had 1 day a week in a complementary pathway, that this might be something that invigorates their working lives. So there are 4 complementary pathways. One is quality improvement, one is medical education, one is clinical research, and one is clinical informatics, but clearly a bit more sexy now to call it digital health. So those are going live in August as well, and to go and test out proof of concept. Does this a way forward? But a real opportunity for trainees remaining in practice, not going out of programme, remaining in practice, to go and test out quality improvement activity. And then not least, we also have had our very recent publication about how modern teams learn together. And in there, this is a real focus about we work together, we should learn together as the modern team. And quality improvement activities provide such a way of working and learning together. So lots of examples, and if you have examples that you'd like to share with us, this is a live document going forward. So, I would say that are we bridging the gap between education and clinical? I think the gap is getting closer in terms of how moving forward. There's still so much to do. And very aptly, and moving on to our next speaker, I'm going to leave you with I think we really need to make sure that we go back to where training starts, and that's with our undergraduates. So Steve very eloquently put, in order to practice medicine in the 21st century, a core understanding of QI is as important as our understanding of anatomy, physiology and biochemistry. So let's always go back to basics. So thank you very much. Your quality improvement team, your clinical governance team, and then it's looking to see what resources are available within your organisation and getting involved across the board. So your DME should be as involved as your clinical side. That's where the connections are made. There are loads of resources. So for an example, here at the college we have the RCPQI, and you can go in and access all sorts of resources. There's the Learning to Make a Difference resources, and coming in the new year will be all of this signposting will be made much easier to go and access by the repository.
Thank you very much. Oh, sorry, got another question?
Oh.
Right up the back. Sorry. not getting away that easily.
Just a question about the non-trainees. So quite rightly, a lot of the training is focused on trainees. But when people qualify, if you like, and become consultants or whatever grade they are, then there's another 20 or 30 years of their life, their practicing life ahead of them. How do you think we can envisage getting them involved and engaged in the training for QI? Because quite often that's even harder than it is to get training engaged.
So yes, I mean there's lots and lots I could talk about. So I focus particularly in that area in the evolution, but in terms of one of the really important areas is as ourselves doing quality improvement, but also how do we support our trainees doing it, but also that it's multi-professional. So in part that's again seeking what's possible with local training. Certainly as a college we offer training for consultants and others in quality improvement. There's the new e-learning, how to get started for quality improvement. And again, more and more focus on that continuous professional development side of things. You're absolutely right, because that's where you spend most of your time. So again, it's about accessing how you can access resources, how you can learn together. I think often rather learning together in a group where it's interactive, you're able to ask lots of questions and testing out what works and what doesn't with your projects is hugely important. And our chief registrars are all here today doing their action learning sets with them this morning, and it's all about their quality improvement and bouncing ideas off what works, what doesn't. And it's interesting how much is common, which a lot is around people and change. So it's not necessarily always just the methodology, QI methodology, it's all the change bit that needs to go together, and that's where every leadership skill you need in the book to enable that to happen, and those go alongside together beautifully.
Brilliant. Sounds like a good place to pause. So finally, we have one more nephrologist, and we're lucky enough to